Good morning. So I want to welcome you all to this MS Views and News, MS Symposium here in Coleman, Alabama. I'm saying it like that because there are people online right now as well. So we want to thank everybody for being here, and I want to thank our wonderful sponsors. So we had, supporting the program, is SANDOZ, which is a division of Novartis. And our exhibitors, we had Alexion, Banner Life Sciences, Biogen, Bristol-Myers Squibb, EMD Serono, Genentech, Novartis, SANDOZ, and Viatris. Why don't we give them a round of applause for supporting the program? Thank you very much. For everybody that doesn't know, my name is Stuart Schlossman. I too have multiple sclerosis. Our speaker is Dr. Brent Parnell. He's a urogynecologist who practices in Birmingham, Alabama at the Alabama Center for UroGynecologgy and Pelvic Pain. Don't worry, guys. He's also going to say something about men with MS and having bladder issues as well. But I want to let you know that Dr. Parnell is very happy. He can't wait to get out of here. His wife and 4 kids are waiting for him, and he wanted me to say hello to them. So I'm saying hello, and I'm letting him take the stage now.
Great, guys. It is so good to be here on this beautiful Saturday morning. I was telling Dr. Legang I couldn't believe that this little jewel was nestled out in the back roads of Coleman. This is a beautiful location to spend Saturday morning. So thank you guys for letting me come and speak with you. It really is a challenge to talk about a quality of life issue to people who deal with so many quality of life issues. Multiple sclerosis is a devastating disease, challenging to say the least. So I know that you guys have a lot of challenges. Bladder problems and bowel problems are one of the many areas that can affect quality of life in people who have multiple sclerosis. So as we go through this, I'm going to be focused on these issues. I recognize that this doesn't affect everybody, but as you'll see, it affects many people who have this condition. So I am a urogynecologist, which means I'm an OBGYN who did 4 years of OBGYN training and then 3 years of fellowship in urogynecology. So my focus is women. Certainly, I understand that this affects men. Most of what I say is relevant to men as well. I'll try to point out where there's a divide, but for the most part, this is going to be for both men and women. So the problem is real. 50% of people who have multiple sclerosis are going to deal with some sort of bowel problem. But even more than that, bladder dysfunction is common in 75% of people. You know, when you think about that, that means that most people that are walking around with MS are dealing with some sort of quality of life impact that involves their bladder and bowels. Now, clearly this will wax and wane. This is something that you're going to see at different times during treatment or different stages in life. But we're going to mostly address the bladder side today. Bladder problems come in a variety of forms. We're going to speak about the ones that I have listed on the screen today. The most common problem that men and women with MS deal with is bladder urgency. Now, bladder urgency is pretty common in the media. If you've seen the commercials with the gotta go commercials, or the little bladder that's dragging the woman off the bus or dragging her through the bowling alley, then you guys know what I'm talking about. Some of you have probably experienced that in real life. Overactive bladder is a specific diagnosis that involves urgency with or without leaking. So not all people that have overactive bladder will leak, but all people that have overactive bladder experience urgency and frequency. Now, with multiple sclerosis, because of the many levels of neurological involvement, you can develop a variety of bladder emptying problems, specifically hesitancy to begin your urine stream, during the urine stream, intermittent streams, or in some cases, inability to empty at all. So that is called urinary retention, and we're going to address that at the very end of my talk this morning. Because of the neurological involvement, you can get both decreased awareness or sensation and increased awareness or sensation. Again, that has to do with different styles of lesions, and unfortunately, it is rarely just one thing. Most of the times, the impact on bladder and bowel function is multifactorial. You can have just the same styles of problems that people without MS have, and then it can be complicated by the various conditions related to lesions with MS. The final thing that I want to mention at the end of the program, again, is stress incontinence. Stress incontinence is common in women in general, in men after certain styles of interventions, but I do want to at least make you guys aware of stress incontinence. So interestingly, up to 85% of people who have MS will experience at least one episode of bladder or bowel incontinence in their lifetime. Now, that doesn't mean that they're going to struggle with it their whole life, but again, that just shows the degree of impact on people's lives. Clearly, during flares or during relapses, these problems are going to be worse, but that doesn't mean that there can't be a persistent impact throughout one's life. Certainly, severity of disease plays a role, and then women just at baseline have a higher risk for bladder problems than men, but with multiple sclerosis, it still impacts men equally. I did want to give a quick shout out for people who love supplements. Sometimes I neglect to mention that we do have good evidence to support the use of certain supplements. I've gone ahead and picked out 4 that not only I recommend to my patients, but that we also see decent evidence for in the literature. If you look at the first supplement, everyone's familiar with vitamin C, and you guys have probably taken a vitamin C tablet during a cold or a flu season. Interestingly, with bladder dysfunction, specifically overactive bladder, if you add if you're using a supplement specifically to treat bladder symptoms, it can actually make it worse. They're highly acidic, they're very concentrated, they're super therapeutic. So supplemental vitamin C is not beneficial, but having vitamin C in your diet is actually very beneficial. So it turns out that nutritional vitamin C has been shown to be effective at reducing bladder symptoms, whereas supplemental vitamin C can actually worsen the problem. Kind of an interesting thing to note. Vitamin D has been studied, and it has some positive and negative literature associated with it, meaning that some research has shown a benefit, others have not. But what we do know is that people that have normal vitamin D levels are less likely to experience overactive bladder. And again, these go for men and for women. Magnesium, as you guys may be aware, is vital for muscle function. So people that run lower magnesium levels can experience bladder dysfunction during periods of lower magnesium level. Y'all probably also know that magnesium can affect your bowels. So if you decide to supplement magnesium, be aware. It works on your bowels pretty solidly. And then finally, D-mannose, which is something that I recommend to most all of my patients who have recurrent bladder infections, has been shown to be effective at reducing bladder infections. And the way that it does it is it helps make the bacteria less sticky. So it tends to help people clear bladder infections before they start. It is not adequate to treat a bladder infection. D-mannose comes in a variety of forms. I typically have my patients ordered off Amazon or go to a local health food store. There's really expensive preparations. There's very inexpensive preparations. I recommend the inexpensive preparations that aren't made in China. It's really what I tell them. The conservative treatments are a lot of the things that you guys are familiar with. When we talk about dietary interventions, unfortunately, anything that sounds or tastes good seems to affect your bladder in a negative way. So I apologize for showing you all the things that are some of my favorite things on the bottom of the slide, but truly those are the things that can worsen overactive bladder. So if you're someone who struggles with urgency, frequency, and urgency leaking, it is fine to have those items that are listed on the screen. But when you have those items, just recognize that there are generally consequences. So like most things, moderation is key. I see a lot of sweet tea or unsweet tea out there. Tea is one of those items. So whenever you have a glass of tea or a cup of coffee, just recognize that there may be repercussions. Some of the lifestyle modifications that people will try are things like preemptively going to the bathroom before they get in the car, or if they're going to go shopping or to a restaurant with friends, going to the bathroom when they get there or prior to leaving. Many times women or men that experience overactive bladder will know where every bathroom is at Walmart, the grocery store, the mall. They're very familiar with these restrooms and they know where the clean ones are. So lifestyle modifications sometimes just involve being aware of ways to decrease the risk of having events. Timed voiding means trying to train your bladder to pee on a schedule. So for example, many people that have overactive bladder are going to go to the bathroom every 30 minutes to an hour. Or if you're experiencing urgency and frequency related to your MS, whether it's with increased sensation or decreased, the goal is to try to void based on a clock. So if you know that you're going every 30 minutes, then it's trying to stretch that out to every 45 minutes or an hour. If you know that you're struggling with difficulty with bladder emptying, then trying to void whether you feel like you need to or not in an effort to try to keep your bladder volume down. That's basically one of the strategies for retention, but also double voiding is a strategy for retention, where for men you would void and then sometimes even need to walk away and come immediately back. But for women, it involves sitting on the toilet, emptying your bladder, standing back up, and reinitiating that whole process, which can initiate that voiding cue or that micturition cue. Pelvic floor exercises and physical therapy are a mainstay of conservative treatment. When we think about pelvic floor exercises, most people have heard the term Kegels or Kegels, however you choose to say it. But Kegel exercises can actually be pretty challenging. It's hard to identify where your Kegel muscles are, especially if you're struggling with awareness and sensation. So that's where physical therapists can come into play. Many times physical therapists can help train you to use those muscles appropriately. And once trained to use them, you can do those exercises at home. Some of the exercises involve floor exercises that honestly look sort of like a Pilates or a yoga pose. Some of them involve exercises that y'all could do while you're listening to me talk this morning. One of my favorite doctors that I trained under in Chapel Hill, on her desk had a koozie that said, "I'm doing my Kegels now." So, if you can do a set of Kegels while you're talking to someone, great, but otherwise you may want to focus a little bit. This is a picture of a woman's pelvic floor. So although the graphic seems a little confusing, imagine that you're looking from someone's belly button into her pelvis. And what you're actually looking at is a floor, the big hole that's in the pelvis that generally speaking is designed for a baby to come out of, that is filled with muscles. That's your pelvic floor muscles. The three holes that are in the middle, starting from the top, are the urethra, the vagina, and the rectum. For men, the hole that's in the middle is missing, and that's actually where the prostate sits. So whenever you're doing Kegel muscles, if you look at that muscle that's labeled pubococcygeus muscle, that muscle that wraps around the urethra, the vagina, and the rectum, that is your Kegel muscle. And that muscle, when squeezed or activated, has the ability to block urine from escaping and has the ability to block the rectum from emptying, especially when it's inappropriate to empty that. So the goal with that muscle is to strengthen it so that whenever you do have an urgency, you're able to suppress that urgency by squeezing it. Typically, these muscles, again, are weakened due to just life, are weakened due to childbirth, or can be weakened due to neurologic conditions. So that's where physical therapists can really play a vital role. When I mentioned pelvic floor exercises, there are actually now many positive resources available online. This organization, I put a picture of the handout on the screen, but that organization, which is called Voices for Pelvic Floor Disorders, they have a handout that gives you really nice instructions on how to do pelvic floor exercises, but there's actually a ton of YouTube videos by women's physical therapists that do a really nice job of helping you understand how to do them correctly. Clearly, I'm implying that there's an incorrect way to do them that can actually make the problems worse. When we're evaluating women or men who have bladder urgency, frequency, urgency bladder leaking, urinary retention, any of those urinary symptoms that we discussed, the initial evaluation many times just involves ruling out bladder infections, sometimes ruling out other bladder pathology like bladder tumors, and then many times we're just looking to see what is the day-to-day life of this person in front of us who's struggling with these symptoms. One way to do that is with a bladder diary. There are simple ways to do bladder diaries. You simply document when you go to the bathroom. You document how often you're going to the bathroom. You can document what you're drinking. And the goal is to look for patterns. Are you going to the bathroom more frequently in the morning once you wake up, more frequently at night once you've laid down? Is it associated with meals? Is it associated with things that you've consumed? And based on that, we're able to then move into a treatment. Now, if we're looking at medical interventions, some of the medical interventions start with medicines, specifically for overactive bladder, urgency, frequency, urgency bladder leaking. These medications have good and bad associated with them. Some of them are effective for some people and not for others. You guys, of all people, are familiar that medicines can have side effects. So sometimes the side effects of these medicines outweigh the benefits. So when we're looking at that first family of medicines, that family is called anticholinergics, or it's got another name called antimuscarinics. This family of medicines has been around the longest. One medicine that you guys may be familiar with on there is called oxybutynin. It was the original medicine. It's been around for a long, long time, still being used, incredibly inexpensive. It has the highest side effect profile of all the medicines. So if someone has tried it and experienced side effects, then we like to move on from that one fairly rapidly. Some of the other medicines in that family, including Vesicare, Detrol, Sanctura, Toviaz, and Ablex, they've now moved into generic form. So we actually have really nice access to most all of those medicines. I think Toviaz is the only one that's not generic now. Each of these medicines has different side effect profiles and efficacy, so it's safe to try a lot of these medicines. Many times we like to avoid this family of medicines in people who have any sort of memory problems, because these medicines do have the ability to impact memory. Now, the second family, beta-3 agonist, is the newer of the two family. That family has been around since about 2010, 2011. Myrbetriq was the first medicine. It's a really nice medicine, low side effect profile, and it works well for a lot of people. Gemtesa is the latest addition. It has an even better side effect profile. The hard thing is that many times we have to try medicines from that other family before insurance companies will allow us to get to this second family. Once we've tried medicines for bladder urgency and frequency, specifically 2 medicines are required in order to access some of these next line therapies. We move into some of the non-invasive but interventional treatments. The first treatment that I have listed is called PTNS. PTNS is an in-office treatment that involves stimulating an ankle nerve in an effort to interrupt abnormal signaling and restore some degree of control over urgency and frequency. PTNS is effective in about 60% of people who try it. Typically, it involves a weekly session that's done in the provider's office, and then after 12 sessions, if it has remained effective, then you move to monthly sessions. This therapy's been around for a long, long time. I think I've got a minute to tell a story. I have a patient who walked into my office just a couple of months ago. She now calls herself the ankle lady. She walked into my office and said, "Dr. Parnell, you're not going to believe this. I broke my ankle. I had surgery on my ankle, and ever since then, I can't control my bladder." And I just laughed at her. I'm like, "You're not going to believe this, but there's a nerve around your ankle that we stimulate to try to give people back bladder control." So this nerve is an extension of one of the third sacral nerves, and we'll talk about that in a minute. There's actually a variety of new technology that is currently coming out. It's not quite FDA approved. I've listed 2 of them. They're eCoin and Blue Wind. If you look at the top 2 pictures, the little coin that you see is called eCoin. It's by Valencia Technologies. And then there's another technology company called Blue Wind that has that little ankle bracelet. eCoin is an implantable device that provides continuous PTNS. It theoretically is going to be implanted in the office. Currently, it's not covered by insurance, but if it indeed becomes covered by insurance, it's a relatively minimally invasive way to provide continuous PTNS to people who qualify. Blue Wind, you actually implant a really small electrode array. Think about it as sort of like the ink container in a Bic pen. It's about this long, about 1.5 inches long, and it goes in that same area in the ankle. And then you wear that ankle bracelet twice a day forever. Wear it for 20 minutes twice a day. I imagine there's pros and cons to that as well. The good thing is the ankle bracelet is replaceable. With the eCoin, it has to be replaced every 2 years. So there are limitations to all of that technology. Now, this is something you guys probably have heard of, and if you're okay with me showing a video, I'm going to show a little video of how we do it, but we'll show the video first and then I'll talk about it. So basically, we go into the bladder with a camera, a scope. It's about the size of a small catheter, And then we inject just under the skin of the bladder with a tiny needle. Remember, this is all magnified. In about 10 locations, we inject either 100 units or 200 units of Botox. It takes about 3 minutes to do. It's relatively, it's uncomfortable. It's not painful. I sit and chit chat with patients while we're doing it. And while we're doing it, patients will ask questions, and they're generally, ooh, that's my bladder, what's that? We generally have a little conversation, so it doesn't require sedation. It's repeatable. So if this is successful, if we try this in the office and someone has a good response, it's something that can be repeated after every 3 to 6 months for as long as it's effective. I typically start with 100 units. For neurologic conditions, it's indicated for 200 units. I still typically start with 100 units. Whenever we inject this, it takes about 1 week for it to become effective. At the end of that 1 week, if it is something that has been beneficial, that's really encouraging, it does continue to become more effective during those first couple of weeks. Some women, when we inject this, or men, it's also indicated for men, some men or women, when we inject this, will experience difficulty with bladder emptying. That's one of the challenges that we have to be aware of. So if we're going to use this therapy, we typically bring people back to the office within a week and check to make sure that they're emptying their bladder adequately. One of the other challenges with Botox is it can result in people developing bladder infections. So if someone is already predisposed to bladder infections, this is not something that I like to do. That doesn't mean that you can't do it. It just means that certainly it's going to increase that risk even more to develop bladder infections. If someone has a great experience with Botox and then we find that a couple of years into the therapy, it's not as effective anymore, then we can increase the dosing up to as much as 200 units. Insurance does cover it. They do require that we've tried 2 medicines first, and then once we get approval for it, again, we can proceed about every 3 months. Some women will get as much as 6 to 9 months out of it, but I typically prepare people to be ready for about every 3 to 6 months to be injected. So the next option for urgency, frequency, and urgency bladder leaking is sacroneuromodulation. Now, this therapy has been around since the mid-90s. It was actually FDA approved in 1996. The original device was called InterStim. And when it was initially implanted, it required a fairly invasive procedure to set up this device. Now it's something that we can do relatively painlessly, either in the office or in the operating room. The way that it's done is you start with a simple trial where 2 temporary wires are placed next to the 3rd nerve in the sacrum. It's done using a needle. Once these wires are placed, then it's attached to an external battery that you wear on your back. It's taped down, or sometimes we'll use a little belt to hold it in place. During this trial, you wear it for about 5 to 7 days, and at the end of the trial, we have been tracking with a diary and with phone calls to see if it's been effective. If someone experiences significant improvement in their bladder, or in this case, bowel symptoms, then we move on to placing a permanent device. The current devices that we use, thankfully, have improved significantly so that now they are MRI safe for even 3T MRIs. And I'm speaking to a group of people who may require MRIs. Once these devices are in place, they can last anywhere from 10 to 20 years. So it can provide continuous relief of bladder symptoms for as long as 10 to 20 years. Once these devices are in place, as you can imagine, they are devices. It is possible for them to malfunction or break, and if that were the case, sometimes we can adjust for that. Sometimes we have to replace them. This also is something that is covered by insurance. Whenever we place one of these, someone does have to have tried and failed 2 medicines, and then we do have to have a successful trial to show to the insurer that this is a beneficial therapy for the patient that we're offering it to. That's a picture of the rechargeable device. That device can last 20 or more years. To recharge it, it's exactly what you would imagine. It looks like a hockey puck, but it goes next to it on the skin, and it takes about 45 minutes to recharge that device. That device has to be recharged 2 times a year. It can be done at home. It could also be done in your physician's office if you are uncomfortable with that. So quickly, I want to switch over and talk about stress urinary incontinence. Stress urinary incontinence is something that most people are familiar with because it's super common. About 30% of people will deal with it in a significant way. Many women will experience episodes in their lifetime, but about 30% of women will claim to be significantly affected by stress incontinence. So that's pretty darn common. The way that stress incontinence occurs is due to 2 main mechanisms. One mechanism can be weakening of the muscle that surrounds the urethra. This is the way that men develop stress incontinence, is if they have excision of a prostate or if they have a urethral resection of a prostate, they can develop stress incontinence due to loss of tone of the urethra. With women, that can also occur. That's typically due to neurologic injury, due to childbirth, stretch injury, that sort of thing. The second mechanism is loss of support of the urethra. So whenever we are talking with women who are struggling with stress urinary incontinence, if we've considered conservative treatment options, we have interventions that address both of those mechanisms for women to develop leaking, and we'll go through all that real quickly. So what you're looking at on the screen is an illustration of 2 of the vaginal support devices that can be used for stress incontinence. So we've already discussed Kegels. So Kegel exercises would be the most conservative way to go. And for some women, especially if you have mild symptoms, that can be effective. But if you start to deal with more significant symptoms and you're not interested in an intervention, these 2 are readily available to women. The first one is a disposable tampon-style device that can be ordered off of Amazon, or some pharmacies will have them. But it's basically placed like a tampon. Most women that use this would be using this for things like when they're exercising, or if they're going on a walk, or if they expect to be doing something really active. It's not something that can be left in long term. It's just like a tampon where it needs to be removed. Alternatively, you're looking at something called a pessary in the lower picture. A pessary is something that can be placed and removed. It obviously has to be removed to have intercourse, but it needs to be removed regularly to be cleaned. When a pessary is in place, for some women, they are able to use those to protect themselves from leaking. For other women, it's not going to be as effective. And it's certainly something that if you're interested, you would just try. You would never know until you tried. This is something that has become more popular over the last 3 years. We've been doing injectables for stress incontinence, for 40 plus years now. The original ones were collagen-based, and people could have allergic reactions to them, so they went away relatively quickly. And then you see a list of the 4 products that are currently on the market. Each of these products has different pros and cons. The main product that I'm going to focus on is Bulkamid because it certainly is the one that has the best outcomes. What these do is they help restore tone to the urethra where that muscle has weakened. So if someone is leaking primarily due to weakening of the urethral sphincter muscle, then we can inject this, and for many women, we're going to see a significant improvement. Bulkamid specifically has about a 90% success rate. The nice thing is it's a quick day procedure. You go in, you get it injected, you go home, and you're physically able to resume all normal activities, so there is no recovery period. I do this under sedation, and that's primarily because it can be a little uncomfortable, but women typically don't report pain afterwards, nothing more than what you would expect after injections, which is typically just a little irritation. So again, this is a video, so if you don't want to watch, avert your eyes, but that's looking at a urethra from a cystoscope, and you can go ahead and start the video. Oh, I think I started. And then basically what we do is we advance a needle under the skin, and Bulkamid is a clear water-based gel. It is literally 97.5% water. But interestingly, as you can see, once we inject it, it doesn't come back out of the hole. It looks almost like Purell. As we inject these, we are watching for these cushions to form, and then as these cushions form, you can see that the urethra closes. Once the urethra is closed, you're still able to empty your bladder, you're still able to do the things necessary to void, but for about 90% of women, they're going to see either resolution of their leaking or a significant improvement. If someone sees benefit with this therapy and then later starts to develop leaking again, we can go back and add more of this material, which is what most women would opt for. Or you can also move up to the other style of treatment that we're going to talk about next. So stress urinary incontinence, most commonly, women have heard about sling procedures. Sling procedures you can hear good stories, you can hear bad stories. The thing with slings is they're like most surgeries. It is very dependent on the surgeon that is placing it. A sling that is placed well has about a 95% success rate long term. A sling that is placed poorly can have all sorts of adventures associated with it. So whenever a sling is chosen for a woman who has stress incontinence and she opts to move forward, it's typically about a 10-minute procedure that again is associated with a very quick recovery and return to function. Finally, I want to mention urinary retention in my last 30 seconds. Urinary retention is something that many people with multiple sclerosis can develop. There's a variety of different reasons that they develop it: detrusor sphincter dysynergia, a hypotonic bladder, etc. We've talked about time voiding, double voiding. Some doctors will try Flomax, which for some people can help with bladder emptying. Self-cathing is the most common thing that would be prescribed if someone is truly in retention. An indwelling catheter is one of those things that we like to avoid, but is certainly out there. And then I have to at least mention that sacral neuromodulation can be used for urinary retention as well. So with that, I'm going to open up the floor to questions. And again, thank you guys for letting me speak with you this morning.
Thank you very much. Somebody wrote D. Manos, what strength?
Yeah, that's a great question. The studies are all over the place on D-Manos. So there was it's called a meta-analysis, which is where they take all the studies, combine them. And interestingly, in the meta-analysis, they could not identify a dosing because the dosing was different in each of the studies. So what I encourage my patients to do is to go with the dosing on the bottle. There's a product out there that most of you have heard of if you deal with any of this stuff called Eucora. Eucora is the most expensive way to get D-Manos. So it's a product that was made by a patient who struggled with recurrent bladder infections. It's a great product, but it's incredibly expensive. You can look at her dosing. She literally just chose that dosing based on her experience. But I just recommend getting the product that you feel most comfortable with, using it as directed on the bottle.
Thank you. There's a question, who does UroLift slings for men and is it effective?
Yeah, slings for men, thankfully, are getting better. Originally, they really had poor outcomes. Urologists are the ones that do it, and typically in most urology groups, they're going to have a urologist that specializes specifically in male slings. It, like female slings, is something that needs to be done by someone who does high volume and gets good outcomes. So the same holds true for men. A good UroLift or a good sling done for a man has great outcomes. If it's not done well, the outcomes are different.
Great, thank you. Person writes about trying to decrease bladder infections. What if you may also have interstitial cystitis?
Oh, that's a great question. Interstitial cystitis and bladder infections look very, very similar. So if you're struggling with interstitial cystitis symptoms or painful bladder syndrome, and you're having negative urine cultures, which means that you truly are dealing with interstitial cystitis symptoms, then there's a whole array of treatments. But going back to some of our supplemental treatments that you may want to investigate online, there's actually a great supplement online that you can find called marshmallow root. I thought about including it, but I didn't want to go down that line. Marshmallow root is an oral supplement that has good evidence to help with painful bladder symptoms. Now, if someone has both interstitial cystitis and recurrent bladder infections, that's where we're trying to, number one, treat the recurrent bladder infections to rule that out as the source of the interstitial cystitis symptoms. I hope that made sense, because they're certainly two separate conditions that both result in very similar symptoms.
All right, bladder hesitancy treatment. What's out there for that, please?
Bladder hesitancy is tricky. It's on that spectrum of urinary retention. So many times with women who are experiencing hesitancy, we would do a study called urodynamics. It's not required, but it's certainly something that helps us understand the source of the hesitancy. Specifically with women who have multiple sclerosis, sometimes that hesitancy can be due to that condition that I mentioned earlier called detrusor sphincter dyssynergia, which has a variety of clinical impacts that we need to be aware of. But if someone has hesitancy that appears to be not related to the sphincter muscle, but related to the Kegel muscle, that's where we would try physical therapy. Many times that Kegel muscle can get overworked. It can become too tight and cause urinary hesitancy. So many times women's physical therapists can work with women on that. It's very common in women. Other treatments for hesitancy, honestly, involve a lot of condition training where you work on relaxation techniques. Flomax is something that is commonly used, and then ultimately sacral neuromodulation.
Thank you. Next, is IC common in MS patients, and are there any tips for people with both?
So interstitial cystitis, just to be clear, is a syndrome, which means that it's an array of symptoms that come together to create a diagnosis of interstitial cystitis. Interstitial cystitis is a diagnosis of exclusion, which means that other things need to be excluded before someone is labeled with a chronic diagnosis like IC. So to be very clear, if someone has had other conditions excluded and then is diagnosed as having interstitial cystitis, there are a variety of treatments, both conservative, medical, and interventional, that can then be tried, a lot of which I've spoken about, some of which we did not review today. The rate of interstitial cystitis in patients with multiple sclerosis, since it is not a neurologic condition or not known to be, should be the same as the general population.
Thank you much. Next question. What is recommendation for long-term treatments such as macrobid for UTI?
That's a great question. We take care of just a great many women who have chronic, unremitting bladder infections. UTI means urinary tract infection, so that implies anywhere from the kidney to the urethra. So when you say bladder infection and urinary tract infection, although they are different things, they are very comparable. So for people who have recurrent bladder infections, once you have ruled out a source for those bladder infections, that would mean ruling out tumors, ruling out stones. If someone's had bladder surgery, ruling out foreign bodies. Once we have ruled out those sorts of things, then placing someone on a chronic low dose of an antibiotic is an acceptable treatment, and for many women can be a huge positive for their quality of life. Men don't tend to get recurrent bladder infections as frequently, and if they did, it is typically related to pathology, meaning like prostate problems, stones, potentially even cancer. So when we're taking care of women with recurrent bladder infections, that's incredibly common. Once you get through menopause and into that period where estrogen is decreased, because of changes in the overall bacterial content of not only the vagina but the bladder, women are prone to bladder infections. So because of that, we will do things like vaginal estrogen creams to try to restore normal bacteria in the vagina. We'll do things like preventative antibiotics or D-mannose. And for most of these women, once we interrupt that cycle of recurrent bladder infections, we can restore that normal sort of sensation and that normal path that most women who don't have bladder infections would experience.
Thank you. For those that have problems during the night with too much frequency of urinating, what do you recommend a time to stop drinking?
Perfect. So when we're talking about women who have nighttime frequency, nocturia, those sorts of symptoms, there are three main conservative interventions that you want to think about. Number one is decreasing fluid intake at least 2 hours before you go to bed. If you can decrease fluid intake, then that will begin the process of slowing down nighttime urine production. The second thing, and one that most people don't want to hear in the South, is compression stockings. So I wear compression stockings at work, so I get to at least show people that I'm wearing them. But compression stockings help prevent lower extremity swelling or leg swelling. What ends up happening to most people at night even people who don't struggle with heart disease or other things, is that as we've been vertical all day long, we develop swelling or water in our legs. The first time that our bodies have an easy opportunity to eliminate that fluid is when we lay flat. So once our legs are at the level of our heart can easily mobilize that fluid. And once it mobilizes the fluid, then we make urine. That is why some people will develop increased urine production at night. It's because of mobilizing the fluid that's in their legs. So if it never gets there, then that can help eliminate sometimes 1 or 2 trips at night. My old front desk lady, her name was Miss Betty. Everybody knew Miss Betty's stockings, because as soon as they came to the front, they would say, Dr. Parnell said that you would tell us about your stockings. And then she would inevitably pull her pants up, show them her cute stockings, and proceed to tell them where they could get them. So compression stockings, number 2. And then the third intervention is to elevate your legs above the level of your heart about 2 hours prior to bed, again, to start that process of mobilizing fluid. If at the end of the day you look and wear your sandals, your socks, your hose, whatever it is that you wear, if there's an indentation, that's water, and that water has to get out at some time.
Thank you. Next one. Macrobid can cause peripheral neuropathy. At what dosage and at what length of time since beginning medicine can a person develop this?
Yeah, that's a great question. Macrobid also has other problems with it. Long-term use can cause pulmonary issues as well. So at the dose that we typically prescribe for prophylaxis or prevention, which is 50 milligrams at night, it is unlikely that someone would develop peripheral neuropathy unless they truly are on it for years. The same holds true when we're doing Macrobid after sex to prevent UTIs that are associated with sex. So I have had patients that have developed peripheral neuropathy, lung-related conditions, but it is typically after they have been on it for years. So although we do try to avoid these medicines in people who have those conditions, if they have allergies that limit our options, then many times we'll use that medicine.
Thank you. Before, when I was asking about the nighttime frequency, I heard you speaking about the women. Did you speak about men?
Yeah, the same holds true for men. If someone truly has a condition where they're overproducing urine at night, it's called polyuria. That's a whole different can of worms. That is treated with medicines, but the vast majority of the time, nighttime urination is not just a medical condition. Many times it's a lifestyle modification issue. Sometimes the overactive bladder medicines will work as well a little bit, or we'll even use a family of medicines called tricyclic antidepressants. Those medicines have side effects that we like to use. The side effects are it helps you sleep better, and it actually works like some of the medicines like Vesicare, et cetera, to help settle the bladder down. So if your doctor recommends an antidepressant for your bladder, it's not because your bladder is depressed, it's because they're truly trying to help you with your nighttime symptoms, okay?
Thank you. A couple of online questions. The first one, ready? Close your ears if you get embarrassed easily. Person wants to know what she could do about her leakage during sex.
Yeah, so that can be one of two things. It can be overactive bladder, it can be stress incontinence. Some women during intercourse will, during a certain point of intercourse, can actually develop such strong muscle contractions that it will force urine out. So that's a form of stress incontinence. Other women will actually develop what's called detrusor overactivity, which is a true contraction of the bladder itself, not your belly, but your bladder. That contraction of the bladder will force urine out. That many times is a neurological response, so it can be activated by irritation of nerves. So it's one of two problems. So if someone has the stress incontinence variety where it's due to increased abdominal tone during intercourse, then those treatments that we discussed, like the injectable or like the sling, can help with that. If it's someone who has overactive bladder and is developing detrusor contractions during intercourse, then that would be the medicines or the Botox or the nerve stimulator.
Thank you for that. Next one writes, does including more protein sources lessen the need to urinate?
I'm not aware that it does. I do know that, when we're talking about lifestyle modifications and dietary changes, the things that we discussed earlier in the slides where we were looking at things to eliminate, Many times overactive bladder is an elimination thing and it's not as much an addition thing. That's one of the challenges with it. So focusing on water-based fluids, being aware of the volume of fluids that you consume, and then recognizing that some of the dietary sources that we have in our diet, like magnesium, calcium, vitamin D, have a positive impact on urgency and frequency.
Thank you. Last one online for right now. Can the stress incontinence treatments work for OAB, particularly the injectables?
That's a great question. Officially, I have to toe the line and say no, but unofficially, we can see really remarkable improvements in overactive bladder when we're doing the injectables. If you think about it, the way that we empty our bladder, which is called the micturition process, there's something that's called a positive feedback loop. So as soon as urine enters our urethra, y'all know what I'm talking about. Anybody that gets to the point where you got to go, y'all know what I'm talking about. Because if you've had kids, you have seen a kid wrap their legs like this and grab their bottom trying to hold it, right? So as soon as urine creeps its way into the urethra, there's a neurological positive feedback that activates the voiding response. So when we're talking about people who develop urgency and they're trying to use urge strategies, since in public we can't grab our crotches and cross our legs, the best thing to do is to do Kegel squeezes until that sensation goes away. If it doesn't go away, then many times that's when you develop that urgency leak. So one of the thoughts behind bulking is that where that feedback loop starts is at the top of the urethra. So if we are able to prevent urine from entering the urethra in the first place, then many times that feedback loop is interrupted. I hope that made sense, because the reality is it is a stress incontinence treatment, but just because of the effectiveness of this product, I've been doing far more of those than I've been doing slings recently. And we're seeing a lot of women who have mixed incontinence, meaning both of those problems, see their overactive bladder get better. I never tell them it's going to, but if it does, it's one of those happy side effects that we'll take every time.
This gentleman, and he wants to know how he can get more sensation in the down theres because MS has robbed that of him.
Yeah, y'all heard me allude to that earlier. That's really one of the challenges is with multiple sclerosis, there are so many complexities, not only to the diagnosis, but to the treatment. And I respect that. When I'm taking care of a patient that has multiple sclerosis, it is truly trying to find the combination of treatments that optimizes quality of life, right? That's ultimately what I do for a living, is try to improve quality of life. So when people have decreased sensation, that's really one of the challenges. So ultimately that comes down to bladder retraining. If that is helpful, then it can help restore some degree of awareness, or at the very least the sense of awareness, if you're at least scheduling that. Beyond that, I'm not even aware that sacroneuromodulation restores that. Many times that's outside of the feedback loop that interrupts.
Should you take I'm going to ask that person to come up here and rewrite
this.
Is
that methenamine?
Yes.
Okay.
That if interstitial cystitis and chromia something, UT1.
Yeah, so those are all very...
Print, please. Print. Keep asking for print.
Yeah, for interstitial cystitis, there truly are a plethora of options. Methenamine, which goes by a brand name of Hipurex, it has the ability to protect from UTIs. So it is many times included in interstitial cystitis, either over-the-counter preparations or compounded preparations. And methenamine is safe and effective. I still prescribe it for patients, especially if they have antibiotic intolerances. It is not adequate to treat infections, but it does a nice job of maintaining a sterile environment inside the bladder. It is not a functional antibiotic in the bloodstream. It only becomes active when it interacts with urine. Some of the other supplements that she's referring to certainly have effectiveness. Each of them is going to have various levels of data. The reality is that I think most of us that deal with interstitial cystitis use different ones that we prefer over others. But for interstitial cystitis, again, it comes down to, does it improve your quality of life? And if so, then it's something that we're willing to try.
For all those that don't know what IC is, I'm being asked to ask you, what is it?
Interstitial cystitis is a syndrome, we discussed that earlier, where someone has urgency, frequency, painful voiding, bladder discomfort, painful intercourse, basically a whole constellation of symptoms. So in order to be diagnosed with interstitial cystitis, things that you would want to have treated and ruled out would be pelvic floor dysfunction of those muscles that commonly causes painful intercourse or voiding and bladder dysfunction. You'd want to rule out overactive bladder, recurrent UTIs, various types of masses, tumors, polyps, etc., that can cause symptoms. Once those things have been ruled out, then officially you're diagnosed as having interstitial cystitis. Now, there are interstitial cystitis patients who have true pathology that can be physically identified on exam. The one that is pathognomonic meaning if you see this, they have this, is called a Hunner's ulcer. And a Hunner's ulcer is where we look inside someone's bladder, we see an ulceration of the bladder. That ulceration causes blood in the urine and significant pain. Those can be treated, but there's something that relapses and recurs. So if someone has a Hunner's ulcer, then we treat the Hunner's ulcers in a variety of ways, and their symptoms get better. The other way that is commonly done in an effort to diagnose interstitial cystitis is to do something called hydrodistension, which is where you look in someone's bladder while they're asleep, and this is important, and then you over-distend their bladder beyond what they would normally be able to tolerate. Many times it's 1,000 cc's, a liter of water. And then once it's distended, you release the water. And then if they have bleeding, which are called glomerulations, if they have bleeding of the bladder, they're diagnosed as having interstitial cystitis. The hard thing is if you do that to my bladder's going to bleed, and I don't have interstitial cystitis. So that is not a pathognomonic way to diagnose interstitial cystitis. So it's mostly a constellation of symptoms that have been where other diseases have been ruled out.
A person writes that her daughter was told by a specialist that Metamucil will help her bladder.
Okay, so what I think the specialist was getting at is that people that have chronic constipation do develop bladder symptoms based on that constipation. So the nerves that control both your bladder and your rectum are the same. They both come from the third nerve root if we ignore some of the autonomic nerves. But whenever we're talking about ruling out other pathology, if someone has a distended rectum due to impaction or constipation, then there's nerve confusion, there's signaling confusion, and many times the bladder will join in that party. So if someone is struggling with constipation, Metamucil is a wonderful supplement to take daily or multiple times a day. Miralax is good to take daily to help avoid constipation. And if you get your constipation under control and then notice that your bladder symptoms improved, then there's a great example of how treating constipation can improve bladder symptoms.
Thank you. Last question. Thoughts on cranberry juice or tablets and Piridium?
Yeah, cranberry juice is, I won't say it's an old wives' tale because it's not totally, but it has been studied and studied and studied, and it does not show efficacy in reducing bladder infections. However, almost every D-mannose product you find out there has cranberry in it because people may not buy D-mannose, but they will buy cranberry. So you will see those paired together commonly. Some very minor and poor studies have shown effectiveness of cranberry, but it is truly something that is pervasive. I don't argue with people who want to try it or who see benefits from it, but the real effective ingredient is D-mannose. Piridium is a bladder anesthetic. Piridium numbs the bladder. It is safe. It can be taken regularly, even though if you get AZO over the counter, you may see only take it 2 to 3 days or 3 to 4 days. The reason that the over-the-counter is labeled that way is so that you're not masking a bladder infection to the point that you then become sick from a bladder infection. But if it's someone who's struggling with interstitial cystitis, has sterile urine, meaning no infection, then AZO or Piridium is safe to take for bladder comfort.
Thank you very much. And let's all thank the doctor. We're out of questions, and he needs to go see his family.
Great. Thank you, guys.
I do want to say thank you again to everybody that's online and thank our supporters, all of our sponsors. We mentioned them all earlier, and that's it. Time's over for all of you online. Thank you. Have a great day.